Okay, hi guys. So nice to see you all virtually here. I'm going to try to give you guys a lecture on paraprosthetic fractures. So the first thing I want to touch on is the epidemiology of this problem. So this is a pretty well-known study that came out now more than 10 years ago that just was meant to show how there's going to be a steep rise in the number of patients in this country undergoing total hip and total knee arthroplasty. And you can see that 2020, where we are now, was sort of going to be the proposed inflection point where these procedures were really going to start to take off even more. And so the point of this is obviously that we're doing many hip and knee primary replacements now. And so because of that, the number of paraprosthetic fractures that we expect to see is also going to go up at a similar rate. This was a study that I put together with Dr. Vale a couple years ago. And basically what we did is we looked at a big national database. And over the course of a 5-year period, we looked at all of the arthroplasties. And so it ended up being about 30,000 arthroplasties, and you can see about 4,500 of them were revisions, and within that revision category, not even quite 300 were paraprosthetic fractures. So if you do the math quickly, that means about 1% of all arthroplasty-related procedures are going to end up being for a paraprosthetic fracture, which again sounds like a fairly small number, and it is, but a fairly small percentage of a really big total number of arthroplasties is still going to make this a pretty large problem at a national level. When we sort of dug into these paraprosthetic fractures and what they were and how they were managed, what we found was what's on the slide there. So the majority of these procedures that were done for a paraprosthetic fracture were ORIFs of some form of the femur. There's probably two reasons for that. Number one, that is probably the most common place to fracture. And number two, that groups together fractures around a hip prosthesis and around the femoral component of a total knee. So the CPT codes didn't allow for us to determine which was which. And then you can see below ORIF was revision. And so revision total hips were quite common, and then revision total knees were a little less common. After that, the percentage of various cases really fell off, and I'm sure this would match your guys' clinical experience as well. We really do very few ORIFs around tibial components. We do very few revisions for fractured patellar components. The bulk of it really is femoral ORIF and total hip and total knee revision. As far as who these patients tend to be, this is the same study that me and Dr. Vale put together. So that group of 259 patients that had the paraprosthetic fractures, in general, these were elderly women. And in fact, we looked at all the possible revision categories in this study, and paraprosthetic fracture had by far the oldest average age. And of course, the reason they tend to mostly be women is because it was an older age group. And then unfortunately, when we looked at some kind of generic outcomes for this group of people, the outcomes were not good. So not surprisingly, most of these people were admitted on an emergent or urgent basis. They had the longest length of stay of any category of revision. Very few people actually went home after their paraprosthetic fracture. 80% went to some sort of rehab facility, or 5% actually died in the hospital. So that was 5% mortality rate for the primary admission of paraprosthetic fracture. It was not 30 days or 1 year. That was 5% of these patients not leaving the hospital after this problem. So we often tell you guys when we talk about hip fractures to lay some crepe with the family, and this is particularly true of paraprosthetic fractures. They really are a very high-risk group. So kind of, just to summarize so far, this is going to be an increasingly prevalent problem, and unfortunately, it's an increasingly prevalent problem in a fragile group of people who are sort of by definition unprepared for this long, technically complicated procedure that they're going to need. And so pretty predictably, this is going to lead to poor outcomes. And so when you see a patient with this problem, that needs to be discussed with them. It needs to be discussed with the family, even more so than for your standard hip fracture. Okay, so that's kind of the epidemiology and the demographics of the folks. So let's get into the kind of nitty-gritty of periprosthetic fractures. We're going to start with periprosthetic fractures around total hips, and specifically around the femoral component. This is the most common type of periprosthetic fracture that you're going to see. And we're going to list the risk factors for various periprosthetic fractures over and over, but they're basically always going to be the same. So anytime you're doing a revision procedure, that's more likely to have periprosthetic fracture. Anytime you press fit a component rather than cementing it in, that's going to put people at risk for periprosthetic fracture. And then, of course, as the bone quality goes down, the risk for fracture goes up. So this is one of the better classifications, honestly, that we have in orthopedics, and it's the reason it's going to be tested on the OIT and on the boards. And this really is the only periprosthetic fracture classification that I think you all actually need to know. But this is a good classification because it's simple and it really does dictate treatment. So for a lot of reasons, this is worth you guys paying attention to. So I'm going to spell this out pretty clearly for those of you who are not familiar with this. So this is the Vancouver classification from Vancouver in Canada. And the classification is first divided into A's, B's, and C's. So A-type fractures are ones that occur exclusively around the trochanters. Those are in figure A here. And they're subdivided into AG for greater and AL for lesser. Okay, pretty straightforward. The middle three images on this PowerPoint, B, C, and D, are the B-type fractures. Okay, so B-type fractures are fractures that occur around the implant. And they're divided into B1s, B2s, and B3s. B1s in this image is labeled B, and this is a fracture that occurs around an implant, but the implant and the proximal bone stock are still stuck together. Okay, it's a stable implant. Now, the implant is not stable relative to the distal fragment. That is always true, okay, with a periprosthetic fracture, but it is stably still in the proximal bone segment. A B2 in this image is C, okay, the middle image. And a B2 fracture is a fracture that occurs around the femoral component of a total hip, but the implant is loose. Okay, and obviously that's a very important distinction when it comes to treatment. B3 in this image is figure D, all right, and that's again a fracture that's in the B category, so it occurs around the implant. But this time the implant not only is loose, but the proximal bone stock is poor. And I know that's a little bit vague, but what it means is that by most arthroplasty standards, the proximal segment is not going to be reconstructable. And then finally, there are the C-type fractures, which is the image labeled E here, the one on the far right. Those are periprosthetic fractures that occur remote from the implant. Okay, so again, the basic breakdown is A, B, and C. A's are trochanteric, B's occur around the implant, and C's occur remotely, far distal from the femoral implant. And the B's are the most common and the ones that are subdivided into 1s and 2s and 3s. 1s are stable, 2s are loose, 3s are loose and have very poor proximal bone stock. Okay, so let's talk about some of these fractures individually. So the first one we're going to talk about is the AG group. So again, that's a fracture of one of the trochanters, specifically the greater trochanter, hence the subclassification B. Okay, these are not that common. They used to be more common. So the traditional way these happened was that with conventional polyethylene, there would be small polyethylene particles that would generate osteolysis of the proximal femur. And these would typically eat away bone around the greater trochanter and eventually make it an eggshell. And then just the pull of the abductors would eventually pull this eggshell off. And that was a relatively common mechanism for an AG-type fracture in the era of conventional polyethylene. We fortunately don't use conventional polyethylene anymore. It's been about 20 years since we've used conventional polyethylene, and so this type of fracture is becoming less common. Okay, much more commonly now, if you see an AG, you need to be concerned that it's not really a fracture of the greater trochanter. It's actually a B2 injury, where the greater trochanter fracture is just the most obvious portion of the injury. Okay, so again, these used to be more common. They're relatively rare now. The traditional mechanism was osteolysis leading to this thing pulling off via the abductors. Without osteolysis contemporarily being common, these are much less common or more often really a subsided stem. But anyway, to talk about how these would be treated, there's basically two ways to treat them, as Dr. Bergman would say, right? So you can do non-operative management or operative management. Non-operative management is going to be reserved for fractures that are minimally displaced and where people still have pretty good abductor function, and probably for the elderly low demand. Okay, and so you might just let these people be weight bearing as tolerated. Maybe you would limit their weight bearing a little bit to toe touch. Maybe you would give them abductor precautions, but primarily you're going to be treating this with benign neglect if it's basically just a radiographic finding. Alternatively, if you have someone who comes in after a fall and the greater trochanter is off, and they have significant displacement, significant abductor weakness, or instability, meaning they also present with a hip dislocation, then that's going to require more than just benign neglect. Okay, the greater trochanter itself, in that situation, you would fix, right? You would perform an open reduction and internal fixation. And how you fix that, you can do it with wires. Most people contemporarily would do it with a claw plate. The other thing you should be prepared to do is to graft the greater trochanter, particularly if it is one of these older generation polyethylenes and that the reason for the fracture was osteolysis, right? Because that greater trochanter might just be an eggshell. So you might need to fix it, but you may also need to graft it, all right? In addition to that, I would say whenever you're going to fix an AG, you should be ready to do more than just fix the trochanter down. For two reasons. Number one, you may get in there, and again, you might find out that it's not an AG. It's actually a subsided stem. The stem might be loose, and so you should be prepared to do a revision in case that's the case. And then number two, anytime you do a revision, you need to be prepared for the fact that the hip may be less stable than it was before the revision. Okay? So you need to be prepared to do things to augment the stability of the hip, even if you're just going in there in your mind to fix the trochanter. Okay, so you need to be able to increase the head size, increase the offset and the length, maybe even convert to a modular dual mobility. But you need to be prepared to address instability that you maybe weren't expecting to have to deal with. You may have to do more than just fix the trochanter back down. Okay. All right, so I think I beat that to death. So let's move on to the ALs. The ALs is an incredibly rare category. I have seen one AL where the lesser seems to have fractured off. Okay, just like the AGs, the vast majority of the time when you see this, you need to be asking yourself, is that an AL or is that really the calcar that's fractured off because the stem has subsided, which is the image that I've put on this slide. So that's not just the lesser trochanter broken off with a big piece of medial calcar. That stem subsided, and that's why the lesser broke off, and that's why the calcar is off. So more often than not, when the lesser is off, that's a subsided stem. That's a B2 fracture. However, if you do manage to come across an AL in your career, and it's an isolated lesser trochanter fracture, you basically treat that with benign neglect, either with just pain control or perhaps protected weight bearing for comfort, the use of crutches or a cane or a walker for comfort. If that's a B2 stem, then obviously that requires something very different. We'll talk about that a little later on here in the lecture. Okay, so that was the A's, the AGs, and the ALs, and now we're going to move on to the most common category, and the most common category that you guys are going to be tested on, which are the B's. Okay, so the B's, again, occur around the implant, and they're divided into 1s and 2s and 3s. All right. The B1s are cases where the implant is still well fixed to the proximal bone stock. Okay. Most primary implants obviously get their ingrowth around the metaphysis. And so in this image, even though the distal tip of the stem clearly is no longer communicating well with the diaphysis of the femur, that's not where the ingrowth occurs anyway. Okay, then that implant is still well fixed to the proximal segment. Okay, and this can be difficult to figure out. The best way to do it by far is to have prior images to compare to make sure that there's been no subsidence. And I think whenever you are planning to fix what you think is a B1, you should always be ready for it to be a B2 and for that implant to actually be subsided. But these do for sure exist. And if the implant is stable, then you just need to fix the broken bone. The only thing is, because there's an implant in the way, you can't fix this proximal femur fracture the way you normally would. You know, most of us, if there was no implant in the way, would probably fix this with an intramedullary nail. Obviously, that's not an option with a total hip implant in place. So instead, you're going to do an open plating of this. And when you do this, you need to do things, or you need to be prepared to do things to increase your fixation in that proximal segment, because a lot of the proximal segment is taken up by an implant that won't accept fixation. And so you're going to want to have locking screws available. You're going to be able to shoot smaller screws around the implant. So this plate that's put on in this image is a large frag plate. It's designed to take 4 or 5 screws. If you put a 3-5 screw through that same hole, you can put it in a larger range of trajectories, and it may help you shoot around the implant. And actually, one of the screws in this image, that top screw just below the cerclage wire, is actually probably a 3-5 screw, where the person has done exactly that. They've shot the screw around the implant by decreasing it from a 4-5 to a 3-5. So that's a nice technique. Locking screws are a nice technique, and cerclage wires, I personally think, are a must when you're doing fixation around a stem. But basically, you know, in theory, this is no more difficult than any other ORAF. You go in there, you get it exposed, you reduce it, and then you definitively fix it with an implant. It's just that fixation in the proximal segment is a little bit more challenging because the implant's there. So you need locking screws, cerclage wires, and again, can name smaller screws around the implant. Okay. The next category is the B2s, and these are, I think, actually the most common injury that we see. So this is where there's a fracture around the implant, and not only is the bone broken, but the implant itself is loose. And again, by loose, I mean it's no longer attached to the proximal bone stock. It's never well attached to the distal bone stock. It's that it's not well attached to the proximal bone stock and the metaphysis of the femur. And again, this can be tricky to figure out. I would argue in this particular example here, it's relatively straightforward. If you think about when you do a total hip, no one would place this implant such that the ingrowth surface of the implant is that far below the original neck cut. Right? It's very unlikely the original surgeon put that implant in that fashion. But sometimes it can be a lot more subtle. You know, depending on if the surgeon made the neck cut a little bit too high or a little bit too low, you know, you don't always have a perfect coincidence of the neck cut and the ingrowth portion of the implant. So again, I said earlier, it's very helpful if you have prior images to compare. And I do think this is worth doing, even though sometimes it can mean trying to call outside hospitals and get old records. It really is a very useful thing to do if you're not quite sure if an implant is stable or not. If you're not sure and you think it's a B1, again, you should just be prepared for the fact that it might be a B2. But in this case, it's obvious. And so what this requires is a revision. Okay, this does not require an ORAF. This requires a revision because the prosthesis is loose. All right. I will occasionally hear people talk about doing things like fixing the bone and leaving the implant in and then coming back later after the bone is healed to then do the revision. That is not a thing, okay? That is not something I would ever recommend. If you don't feel comfortable doing revision arthroplasty, that's fine. Just send it to someone who does, okay? These people need one operation, if at all possible, and then to get up and be immediately weight-bearing. So again, don't just piece back together the bony fragments and then tell the patient you're going to come back later to do the revision. You do this all in one surgery, okay? So what you do is you go in there, you remove the prior implant, and sometimes that's as simple as picking it out of the rubble. Sometimes you do have to osteotomize some of the remaining bony pieces off of the implant. And then you're going to put a new implant in, obviously. And the majority of the time, contemporarily, when you put a revision hip stem in for a periprosthetic fracture, we use the implant that is shown here. This is a fluted modular tapered stem. Okay, it's basically a modular Wagner. Okay, so you can kind of see that the stem itself is two pieces. There's a distal portion, and there's a proximal portion that includes the neck. And this actually comes in two pieces. And the proximal body segment comes in various sizes, which is very helpful. You can add length by increasing your proximal body size. But basically, the way this is designed to work is you're not supposed to get ingrowth proximally in the proximal femur around the fracture. All the ingrowth occurs distally in the intact distal portion of the femoral diaphysis. So you basically pot this stem distally, and then you build off of it proximally. So unlike a primary total hip implant where the ingrowth is in the metaphysis, the fixation here and the ingrowth is all in the diaphysis. Okay, so you basically pot the stem distally, build the implant off of that distal stem tip, and then you just cerclage the proximal fragments around the stem. It's a little bit more complicated than that, but that's the basic concept. Okay, that's the basic way you do a revision. Okay, the last type of B is a B3. The B3s, again, are fractures that occur around a total hip implant. But in this case, the stem is loose, or at least it's typically loose. And unfortunately, the bone quality is very poor. And it's so poor that the treating surgeon decides that it is not going to be reconstructible using typical implants. And so there's basically only two ways to deal with this. One way is to try to rebuild proximal bone stock if you think it's deficient. And the other way, which is contemporarily becoming much more common, is just using a megaprosthesis, using a tumor prosthesis, heavy metal. Okay, so rebuilding bone stock was a bit of an older concept. It's still done a little bit, but it's definitely falling out of favor, and I would argue it's falling out of favor because it doesn't work well. It does not have a good track record. But if you think someone doesn't have enough proximal bone stock, you can try to increase their proximal bone stock by doing things like using allograft struts, by doing something called impaction grafting, where you take a bunch of morselized cancellous allograft and you jam it down the femur. And there's a whole series of instruments to get it to sort of jam against the side of the tube of the femoral diaphysis, and then you cement an implant into that. And then the final way is to do something called an allograft prosthetic composite, where you literally take a cadaveric proximal femur, you cement an implant into that, and then you cement that whole thing into someone's native distal femur. So all of these things are, again, somewhat older ways to try to rebuild proximal bone stock when it was deficient. Again, I think the contemporary way to deal with this is not to try to rebuild insufficient proximal bone stock. It's to use heavy metal. It's to use a tumor prosthesis, namely a proximal femoral replacement. Okay, there are plenty of downsides to using a proximal femoral replacement. Obviously, the abductors don't attach, or they don't attach well to these implants. And so stability is an issue. And obviously, whenever you take out bone, that bone's never going to come back. But it seems to me that these are going to have a better track record than the other three things that I mentioned that were attempts to rebuild proximal bone stock. Okay. All right, so that ends the Bs. And then after that is the Cs. So Vancouver Cs, again, are fractures that occur below a femoral component, and they occur pretty remotely to the femoral component. So the fracture is not actually around the stem at all. It's in more of the distal femoral shaft or the distal femoral metadiaphysis. And the only reason that these are at all technically challenging is because, again, you can't use a nail to fix this. You're going to have to use a plate. And the proximal femur has an implant in it that reduces your ability to get purchase. So just like I was saying before with the B1s, these just require you to have other things available for proximal fixation. It's just things like cerclage wires, small screws, and locking screws. And the nice thing about a C as opposed to a B1 is that since the fracture is further distal, there is going to be some available bone stock distal to the tip of the stem, which means you're always going to be able to at least get a couple of screws into bone before you get to a point more proximally where you're stuck with cerclage wires or stubby locking screws. So these are relatively straightforward. You're going to open, reduce, and fix these with a lateral plate the vast majority of the time. Okay, so that concludes the Vancouver classification. And as I said before, I think that is really the only classification that you need to know, both for testing and frankly for practical purposes. Okay, that's the only one that should be on the tip of your tongue, and you're going to want to be able to use without a whole lot of thought. I'm going to use some other classifications here to round out the talk, but none of them are ones that I'd recommend that you sit down and try to memorize. I'm just going to use it as a framework to talk about common scenarios where you might experience a fracture. Okay, and so the next thing we're going to talk about are intraoperative periprosthetic fractures of the femur. So you're doing a total hip and something goes wrong. All right, and so this is definitely something worth knowing about. Okay, the vast majority of you, at the very least, are going to be doing hemiarthroplasties when you get out into practice. And I'll remind you that the fracture rate intraoperatively during a press-fit hemiarthroplasty is 7%. All right, so this is not a rare problem if you press-fit stems, and so this is something that you're going to want to be able to think through, even if you haven't memorized the classification. Okay, so the first column here are the A's. Again, don't worry about the A, but all the ones in the A category are fractures that occur in the metaphysis of the proximal femur while you're trying to put a primary stem in. Okay, and they can come in a couple of flavors. So the first flavor, the A1, is a fracture in the proximal femur that's just a hole. All right, and so why in the world would you have a hole in the proximal femur when you're doing a primary total hip? Well, one reason is you could somehow put the stem in such a way that the bottom of the stem goes out the side of the femur, but that's very rare, actually. Hopefully none of you guys will ever do that. But a not uncommon scenario would be a hole in the proximal femur metaphysis due to the prior placement of hardware. So the example I've thrown up here are cannulated screws, right? So those aren't fractures per se, but they're a really great way to generate a fracture, okay? And so you need to be mindful when you're putting a primary total hip in that when you take out those screws, there are going to be these 3 potential fracture sites when you're putting the implant in. It doesn't mean you have to necessarily not use a primary hip stem, but at the very least, if you have a hole, you need to make sure that your femoral stem, and I would argue your femoral ingrowth, bypasses this region, okay? Which should be fairly easy to do with any primary stem. The majority of primary hip stems are going to have ingrowth below the area where cannulated screws might go in. But conceptually, the point I want to make is that if you have a hole in the metaphysis, you need to make sure you bypass that hole with your implant. The second thing that happens, and this is probably the most common scenario, is you're impacting a primary hip stem, and suddenly the hip stem goes in a little further than you were expecting, and it's because you've cracked the calcar, okay? And probably a lot of you have been in the OR when this has happened. So this is something that you need to know how to deal with. So it's very straightforward. All you need to do is remove the implant that you were impacting. You need to get the cerclage wires out, and you need to cerclage that back together, and then you insert the primary stem. After I do that, I leave these people toe-touch weight bearing for 6 weeks to allow for some healing. But some people don't. But I think that's the cautious thing to do. But what you don't do is leave the implant in and cerclage around the implant with the implant still in. Okay, you've got to take the implant out, cerclage the bone back together, and then drop the implant back down. Okay. The A3 that you see here is basically the same as an A2. It's just that it's not just a crack. The thing is totally displaced. There's not really a difference here in management, I would argue. It's basically just the same thing. You got to take the implant out, cerclage it back together, and then drop the implant back down. If that crack goes very far, okay, or the fracture was very displaced, I think it would be reasonable to consider converting to a more diaphyseal engaging stem. But depending on where you're working, that may not be an option, right? So even for me at the county hospital, that's not an option I have available every time I do a primary total hip. So the way you're usually going to bail yourself out of a crack or a frank displaced fracture in the calcar is to remove the implant, cerclage it back together, and then put the implant back down. Okay, so that's metaphyseal intraoperative problems. Okay. The right-hand side of this slide is basically the same thing, but now you've moved down a little bit. You're in the diaphysis, okay? But you're in the diaphysis somewhat around the implant that you're trying to put in, okay? So just like the A's, the B1 is a fracture, or I would say a potential fracture in the diaphysis that's just a cortical perforation. And where this has come up for me is the exact image that's shown here. So someone who has a failed DHS that now needs to get converted to a total hip. So in those cases, you should not just use a primary hip implant because you will not have a primary hip implant with engagement in the metaphysis that bypasses all these holes. So instead, in my mind, what you have to do is use a diaphyseal engaging implant that bypasses these holes by at least 2 cortical diameters. Okay, so that's going to be, in my hands, that would be that fluted modular tapered stem. There are also non-modular Wagners that you could use, but you need a diaphyseal engaging stem, in my opinion. When you get to the B2s, again, just like the A2, this is a fracture in the proximal diaphysis. That's a crack, and the treatment is the same as for the B1s. You need to remove the implant, get the fracture together, cerclage it back together, and now since you're in the diaphysis, you shouldn't just put in a primary hip implant. You should put a diaphyseal engaging stem down if at all possible. And then the same for the B3s. So this is just a displaced version of a B2. Again, you need to remove the implant, clamp it, cerclage it, and then put a diaphyseal engaging stem down that bypasses this problem by at least 2 cortical diameters. Okay. All right, and then finally, again, just like the Vancouver classification, there's the C's of intraoperative paraprosthetic femur fractures, and these are remote from the implant that you're trying to put in. So you might ask, well, when would this possibly come up? But this could come up if you're doing a very stiff hip and you're trying to dislocate, and instead of dislocating the hip, you cause a distal fracture. Okay, I've never done that, but I have torn someone's MCL trying to dislocate them. And you know, some people, some elderly folks, their bone is going to be weaker than their ligaments, and so it is probably possible to get a torsional fracture distally during something as benign as trying to do a dislocation for an arthroplasty. So that's when this might come up. And the way you're going to do this is the way you would treat a Vancouver C. So you're going to put in the total hip, and then you're going to fix the fracture distally using implants that are going to allow you to get good proximal fixation around your new total hip, and that span both the total hip and the fracture. Okay? All right. So that's fractures around the femur. For total hips. Now we're going to touch on fractures around the acetabulum. Okay, these are much less common and are things that should be dealt with by arthroplasty surgeons or trauma and arthroplasty surgeons together. These are not the sort of things that I think are going to be dealt with nearly as commonly out in the community. And again, the classification system I'm going to go over here is not one that I think you need to memorize at all. But at the very least, I want to talk you through the various problems that can occur around a total hip acetabular component. So the risk factors here are the same as the risk factors for the femur. Press fitting is a risk, particularly if you under-ream by more than a millimeter. And again, if you have poor proximal bone stock, you're going to be more likely to fracture. The imaging would probably be what you would predict. You're probably initially going to get an AP pelvis that identifies this problem. Then you're going to get dedicated hip imaging, dedicated acetabular imaging, meaning Judet views. And Whether or not you get a CT scan, I think is going to be provider dependent. I often say that I think the indication for a CT scan in any one person is just an individual provider's desire to have some more knowledge. So some people may want it, some people don't. If you want it, then go ahead and get it. Certainly in my hands, I think it would usually provide some additional useful information. It's just going to be limited because obviously there's going to be a lot of artifact from the implant. So this is the classification system for periprosthetic acetabular fractures. Again, don't memorize this. I'm just going to use this to walk us through some various scenarios that you might come across. Okay, so the first type of periprosthetic acetabular fracture is one where it occurs intra-op during the insertion of an acetabular component. So you're doing a primary total hip for somebody, you impact the cup, and you get an acetabular fracture around this new implant you're trying to insert. And this has actually happened to me once. So there's basically a couple of possible scenarios. One option is you've impacted the cup, you've judged the cup to be totally stable. It's inherently stable in the bone. However, you've noticed there's a crack, let's say, in the posterior column. If that's the case and the cup is stable, then you can just put multiple screws in through the cup, and that's all you have to do. Okay? If alternatively you impact the cup and there becomes a widely displaced fracture of the posterior column, you should not, in that case, just put multiple screws through the cup. You should remove the cup, fix the fracture, okay, and then put the cup back in. Sounds pretty reminiscent of how you should treat intraoperative femur fractures when you have this, displaced calcar fracture. All right, you don't try to fix the fracture around a cup. You remove the cup first, fix the fracture, and then re-impact the cup. When you re-impact the cup, I recommend you ream line to line, so don't under-ream. If it's a 54 millimeter cup, don't ream to 53, ream to 54. It means you're not going to get as good of a press fit as you normally would, but it also means you're less likely to displace this fracture again as you impact the cup. Okay? And then the final scenario is when you have an intraoperative fracture that you don't even realize until you're in the PACU. Okay, and this has been this scenario for me. So I impacted a cup, and then post-operatively, actually I was still in the OR, but post-operatively, I got an AP pelvis and I saw a fracture, okay, around the acetabular component. So what do you do then? You're closed, and how do you proceed? As it turns out, that will be answered by looking at how to deal with traumatic injuries. So we'll come back to this in a second, all right? Okay. Another kind of periprosthetic fracture, but one that's quite different from the scenario I just talked about, is periprosthetic fractures around the acetabulum that occur during acetabular removal. And these aren't really periprosthetic fractures per se. Really, what it is bone loss that occurs with revision procedures. So you go in there, you have to remove a cup, and in the process of removing the cup, you lose more bone stock than you were hoping for, okay? There's a bunch of bone stuck to the back of the original acetabular component when it comes out. So what do you do then? And the answer actually is pretty straightforward, okay? The technical solution can be complicated, but the theory behind it's pretty simple. Generally, if you have at least 50% of the rim left intact after removing a shell, you're going to be able to impact a new cup and it's going to be inherently stable. And if that's the case, just put a bunch of additional screws through the cup. Alternatively, if there's enough bone loss, and generally what's quoted is more than 50% of the rim, but 50% is just sort of a number picked out of nowhere. But if you try to impact a new cup and it's not inherently stable, then of course you can't just put a couple of screws in and hope that that's going to be enough. You need to do something else to augment the initial stability of the cup to prevent the cup from spinning out, okay? And this is why we'll use things like augments, use things like cages, okay? These are all things to make the cup more geometrically inherently stable while you're waiting for ingrowth, okay? So it's actually fairly straightforward. If you're removing an acetabular component and there's a bunch of bone loss, just ask yourself, when you're impacting the new cup, is this cup going to be stable or not? If it is, then just go ahead and augment that with a couple of additional screws. If it's not, then a couple additional screws ain't going to cut it. You need to add something like an augment or a cage, depending on the specific anatomical scenario, to make that cup more stable while you're waiting for ingrowth. Okay, another scenario is trauma. So basically, someone has a total hip that's in place, and then they fall over, and then they have a crack around their acetabular component. Okay, there's basically two options. One is that you think that the acetabular component is still stable. And there's not a specific way to define this, but the best way to define it is that you have an old radiograph and you don't think the cup has moved at all relative to the old radiograph. If that's the case, you can just have someone not bear full weight for, say, 6 to 12 weeks, and then allow them to weight bear. And if they go on their way and are relatively painless, then the cup was probably stable. If after that 6 to 12 week period they start to weight bear and they are painful, it's probably a loose cup. Or if you get serial radiographs and the cup is moving, that's obviously a loose cup. Okay, so, and that's option 3B here. So if you have a cup that's clearly moved, either initially or on repeat radiographs, that requires a revision. All right, so you're going to have to go in there, you're going to have to fix the fracture, and you're going to have to revise the cup as well. I said that intraoperative fractures that you don't recognize are also managed as if they were traumatic injuries. And so if you have an intraoperative fracture but you didn't realize it, which was again the scenario that happened to me one time, I got an x-ray and saw a quadrilateral plate fracture. I just referred to this portion of the classification. Okay, so what I said was, okay, well, I see a quadrilateral plate fracture that I wasn't expecting on my postoperative x-ray. However, I thought that cup was stable intraoperatively, right? If I didn't, I wouldn't have left the operating room. I probably would have figured out that I had caused a fracture that I didn't realize initially was there. So I impacted that cup. It was inherently stable, and so I know that that falls into the 3A category here. And I'm just going to limit that person's weight bearing for, I think I did 3 months. And lo and behold, it did heal around the cup, and that guy's about 2 years out now. All right, so if you have an intraoperative fracture that you don't realize, usually it's going to fall into this 3A category, meaning you thought you had a well-placed cup with no fracture and it's stable, and then postoperative x-rays show something else. You can usually just treat that conservatively, actually, unless the cup starts to move postoperatively, and then that's obviously going to fall into the 3B category. The next two categories I just want to go through really quickly because they're very complex and I really can't touch on them at all meaningfully in this lecture. But just to say really quickly, there are fractures that can be due to very, very bad osteolysis from very compromised bone stock. We used to see this more with conventional polyethylene. The rules of dealing with this in a very generic way are the same as the rules for dealing with poor bone stock for any other reason. Such as the type 2 that I went through earlier, when you remove a cup and you accidentally remove more bone than you want. So if you have compromised bone stock from osteolysis, if you can get a shell in there, and generally the number is 50%, but if you can get a shell in there and it's inherently stable, you can just augment with additional screws. If you can't get it to be inherently stable because there's too much bone loss, then you need to do something else, and that something else might be a cage. It might be an augment. It might be multiple screws through the cup also. But if you can't get an inherently stable shell, just screws alone is not going to cut it. Okay, and then the final category, just for completeness, is pellet discontinuity. For those of you who are a little bit junior and maybe don't know what this is basically when you have a transverse acetabular fracture and the top and bottom halves of the acetabulum are no longer in continuity. And so these are very complex problems, and not something I can really touch on in any detail here, nor is it something that I have ever dealt with personally in my career. Another good reason I probably shouldn't be going into too much detail here, but in theory, the way you deal with these is very simple. Okay, again, if you can if you can get 50% rim fit, if you think you can get an inherently stable cup, then you can fix that discontinuity and put multiple screws in. If you can't get the cup to be inherently stable, again, generally that's because there's less than 50% rim fit, then you need to do something else besides just extra screws through the cup. You need to use cages, you need to use augments, or you can use this technique called distraction, where you just jam a cup in that's far too big and wedge these pieces of bone apart and have the soft tissues hold the cup in place. by pressure on the two bony fragments getting squeezed back together by the soft tissue. That's called distraction. The final category here is when you have a discontinuity and it's due to pelvic radiation. Obviously, this is very uncommon unless you're poor Dr. Woostrak. But the thing to know about fractures anywhere in the body, so it's also true in the pelvis, is those don't heal if in a prior irradiated bed. And so you don't try to put in a cup that's going to ingrow. You just cement something in place. Okay. All right. So we're going to finish up with periprosthetic fractures around total knees. Basically, you can have fractures around the femur component or fractures around the tibial component. And the risk factors for these are going to be the same as for fractures around the hip. Basically, revision knees more often have this problem. People with poor bone quality more often have this problem around the knee. And the one specific risk factor is femoral notching. What femoral notching is when you're making that anterior cut, if you undersize the femoral component, you will start to dig into the metadiaphysis of the proximal femur. There's no question that in biomechanical testing, femoral notching increases the risk for fracture. However, there does not seem to be any clinical data that shows that minor notches put people at any additional risk. Okay, so even though surgeons with some regularity tend to make this error, fortunately the clinical significance of it tends to be pretty low. Okay, so there really aren't any classifications around total knees for paraprosthetic fractures that I like. There are classification systems, but I don't like them, and so I didn't feel like talking about a classification system that I would never use. So instead, I think of these problems very simply, and it mirrors the Vancouver classification, which I think is a good one, obviously. So basically, the first question you have to ask yourself, if there is a supracondylar femur fracture around a total knee, is do you think that femoral component is stable or not? It's actually quite rare that the femoral component is loose. All right. If the femoral component is loose, then just like a Vancouver B2, that requires a revision. It's going to require a complex revision. It's often probably going to be a distal femoral replacement. Okay. But the majority of these, there's going to be some meaningful bone stock still attached to the distal femoral component. And so at that point, you're going to fix that injury. Okay. At least that is the most common way to deal with these problems. And you're going to fix that either with a lateral plate, most commonly, or an intramedullary nail. The things that are going to lead you towards intramedullary nails are if you have a CR knee where the box is open and a nail can go through the implant. If you have a large distal segment, so you have a big piece of bone to fix into, because intramedullary nails don't have quite as many fixation options as plates do. And we like to use nails in elderly people, okay, because we think they can weight bear sooner. If you are going to do an intramedullary nail for a supracondylar paraprosthetic femur fracture, I would strongly consider blocking screws, because again, the locking options around retrograde femoral nails are less than lateral locked plating. And so you can reduce motion and the chance of catastrophic failure with some additional blocking screws if that's possible. Again, the alternative retrograde nailing for stable femoral components is an ORAF. Again, this is typically done with a lateral locked plate. Things that generally push us towards plating are PS knees, where a retrograde nail is frankly impossible because there's a closed box that you can't get through, and also shorter segments. So the distal piece around the femoral component is smaller. And again, there are more fixation options typically in a lateral locked plate than there are in an intramedullary nail, so that would also push you towards plating. The one caveat to this slide is that there are people who are contemporarily thinking about doing distal femoral replacements even when the femoral component is stable, so doing a revision arthroplasty rather than fixing it. And the reason for that is if you do a revision arthroplasty with a distal femoral replacement, you can let these people immediately weight bear, which is typically not going to be true with for a lot of people with supracondylar femur fractures around a total knee. And so because in the very elderly, the need for weight bearing may be great, there are some people that are advocating doing distal femoral replacements, even for femoral components that are stable. We're actually going to be part of a randomized trial at UCSF and at the county that's going to try to look at this. But that's sort of a caveat to what I have up here. And then the last thing I'm going to talk about very quickly, because it's not common, is periprosthetic fractures around the tibial component of a total knee arthroplasty. Risk factors are the same as we've been saying before, just poor bone quality and prior revision. You're going to fix these with my classification the same way I address supraconic femur fractures. So if the tibial component is loose, that's relatively theoretically straightforward, right? That's going to require a revision. The revision itself might be complicated, requiring things like diaphyseal engaging stems and cones and things like that. But theoretically, that decision is easy to make. If the tibial component is loose, that needs a revision. If the tibial component is stable, then you're typically going to try to do an ORF instead. But the tibial component is going to get in the way. And so most often, this is going to have to require locked plating to sort of overcome the osteoporosis and the limited fixation in the proximal tibia around the implant. This particular image, by the way, where they fixed the femur and the tibia, was just a horrible example of how to do this that somehow got published in the literature. So I'm not advocating this particular reduction or plating technique, but I just couldn't resist copying and pasting it into a talk. So anyway, so that's all I have for you guys. The bottom line for paraprosthetic fractures around the knee is if the component is stable, you're going to try to ORF it. If the component is loose, it's going to require a revision. And of course, again, that really mirrors the Vancouver classification for B1 and B2 fractures. So hopefully that was helpful. I do have some cases that I'd be willing to discuss with you guys on the 22nd during the time that this lecture was supposed to be given. So maybe I'll see you then to go over some cases. Thanks, guys.